Good afternoon. Welcome to Brahm Center's Health Talk this Saturday. Brahm Center would like to wish all our Muslim friends a happy Hari Raya Puasa. And today we have the pleasure of inviting Dr. Jerome Goh back again for another talk. Good afternoon, Dr. Goh.
Hi, good afternoon, everyone. Thank you for the introduction.
Dr. Goh, thank you for your talk last week about depression. It was definitely very informative, and we really had a lot of interest from our attendees. And I think today we will equally have questions for you. Would you like to begin now, Dr. Goh?
Sure. So maybe I just start with the introduction. I'm a psychiatrist working in IMH. So my background is actually more of adult psychiatry and specifically in the subspecialty of forensics. Okay, so today we're talking about slightly different from what most psychiatry would be managing, and it is about the symptoms and management of dementia, okay, which is a clinical syndrome. So for this presentation, I would like to give credit to my fellow colleague in IMH. So he is actually Dr. Yao Feng Yuan, who works as a consultant psychiatrist in the Department of Geriatric Psychiatry, where people with dementias are often managed. Okay, and he's also the director of the Aged Psychiatry Community Assessment and Treatment Service, or what we call APSCAT, which is kind of a community service for the elderly. Okay. So these are largely from his slides for caring for persons with dementia, but I added in only a few of my own slides. So for the purpose of this talk, I would like to start off with talking about how common dementia is and what are the common types of dementia that we often see. And about management, how do we lower the risk of dementia? And what are the symptoms? How do they present the symptoms of dementia? And when you have a team managing them, a medical team usually in our context will refer to not just psychiatrists, or sometimes it's also medical physicians, sometimes it's members of the allied health like social workers, case managers, and psychologists. Okay, those team members who are helping clients with dementia. And I think more importantly is advice for caregivers, because dementia is a chronic condition and caregiving can often be distressing at times, and we need to equip caregivers with the necessary skills to look after sufferers of dementia. So first off is how common is dementia? We know that in Singapore we have an aging population. So this is a census. I'm sure there's more updated data. 2014, the number of Singaporeans aged 65 comprises 12.4% of the resident population. By the year 2030, the percentage for those aged 65 years and above is projected to increase to 18.7%. So in absolute numbers, the elderly population aged 65 years old and above will increase from above 300,000 in 2007 to 900,000 by 2030. And why is this important for dementia? Because dementia is actually a fraction of the elderly population. And the more elderly they are, we're expected to see more diagnosis of dementia. Okay, so you can see in this slide that the number of people with dementia is currently estimated, this is worldwide, 44.4 million. And the prevalence of dementia in Singapore is 10% of the elderly aged 60 years and above, according to IMH research study in 2015. So which means that 1 in 10 of those aged 60 and above has dementia. So if you look at the specific age groups populations, so for example, those in the 60s compared to those in the 70s, 80s, and 90s, you're going to see in the older age group, 70s compared to the 80s, there's going to be a slightly higher percentage of those with dementia compared to the younger age groups. So it gets more and more. We know that ours is a society that is rapidly aging, This is actually from a news article in 2007 or 2008 rather. We have reached a critical juncture in that year in which the number of old people will match the young for the first time, okay? And this is the inflection point, as you can see from the graph, right? We start to have more and more elderly in our population and less younger population, working adults and schooling. So this is going to be a greater burden on the society as a whole. So which is why we are back to talking about how do we best manage dementia so that the impact on the individuals and on the caregivers, because you're going to get less and less number of caregivers for each person with dementia in the years ahead. It's going to be great. So if you look at the dementia projection in Singapore, you can see that it's a slowly rising trend. So looking at this year in 2020, for example, there's just over 50,000. And it's only in 10 years' time that we are approaching doubling the numbers. And it gets, the number will get higher and higher beyond that. But what are the common types of dementia that we are seeing? The most common that usually we saw is Alzheimer's dementia. So that comprises around 50% of all those with the diagnosis of dementia. And this is followed almost in equal numbers by vascular dementia. And there's a smaller group of other kinds of dementia that forms the last quarter of the diagnosis. They are mainly differentiated by some, not so much by the, I guess, by the pathology, I would say. So the main differentiation by the pathology or what is the underlying disease process that caused the dementia. Alzheimer's dementia was actually described quite early. In 1907, Alzheimer published a lecture which is titled A Characteristic Serious Disease of the Cerebral Cortex. So this described a 51-year-old woman who showed as one of her first disease symptoms a strong feeling of jealousy toward her husband. And very soon after that, rapidly increasing memory impairments. She was disoriented, carrying objects to and fro in her flat and hiding them. And sometimes she felt people wants to kill her and began to scream loudly. So after 4 years of sickness, she passed away. Okay, so it was a very early description, but I'll talk about more of the symptoms later on. So as I said, the main differentiating factor is the underlying disease process that leads to different diagnosis of dementia. So in Alzheimer's itself, you see some changes in the what we call the neurofibrils, and there are some what we call plaques that is seen in the histopathology, which means that they actually cut out sections of the brain, slices of the brain, and look at under the microscope. So Alzheimer's disease is characterized by two abnormalities in the brain. They have what we call the amyloid plaques, which are just unusual clumps of proteins found in the brain, and neurofibrillary tangles. So these are kind of twisted filaments in the brain when seen under a microscope. So it's something like this. The histology changes. If you look at the right picture, there's a picture of a normal. Neurons are actually the brain nerve cells. And in Alzheimer's itself, you can see the neurofibrillary tangles, okay, which appears, and the plaques, which are protein clumps, as I mentioned earlier on. Okay, and on the right side is another picture of a neurofibrillary tangle and an amyloid plaque. So if you look at the brain grossly, what happens in dementia in general and specifically in Alzheimer's is that the brain volume shrinks. So you're going to see obviously less neurons or the nerve cells in the brain. So it's a much smaller brain. In particular, the fissures, what we call sulci, gets deeper. Okay, so the grooves gets deeper and the brain itself gets smaller. And you can see that it can affect particular sections of the brain. which can be the language portion and the memory. So this explains a large part into the clinical presentation, how patients with dementia presents. Okay, so there are problems with language, problems with memory, the brain volume shrinks, and that results in a brain, what we call cognitive deficits, a decline in the brain functioning. So the next, remember, 1/4 of them will have what we call vascular dementia. It is the second most common cause of dementia after Alzheimer's. And sometimes you can see them coexisting together with Alzheimer's dementia as well, what we call a mixed dementia. The thing about vascular dementia is that I think it's somewhat preventable, as I'll talk about the causes later on. In vascular dementia, it often progresses in a stepwise manner. Okay, so sometimes they are more or less stable for a while, and then they suddenly got worse. And at the level, they got stable for a while again and got worse again after that. Okay, when we learned about the underlying reason, we will begin to appreciate why this is the case. So there will be lapses in memory or reasoning abilities, some problem with their reasoning, which is followed by period of stability in the functioning, only to give way to further decline. So why do we have vascular dementia? Okay, very often is after a stroke, the symptoms start to appear. Okay, sometimes these strokes, which is basically, it can be a blood clot in the vessel, or it can be the blood vessel bleeding into the brain. Okay, it can be caused by a series of small mini strokes, which on the outside is unnoticed, but nonetheless cause damages to the brain. Okay, so they can be clots, I can be bleeding, as you said. Sometimes it may be a result of what we call atherosclerosis, where the blood vessels in the brain slowly got clogged up with, for example, cholesterol plaques, or it can be because of a high blood pressure, which cause hemorrhage into the brain. Okay, sometimes it can also be due to something outside of the brain itself. When you see abnormal heart rhythms, it can be sometimes clots which is being thrown out in the blood vessels and goes to the brain as well. So for various reasons, I appreciate that sometimes strokes, when they start to hit the brain, they have deficits. When there's a temporary pause in these mini strokes, there's a period of stability. So many have a history of high blood pressure, high cholesterol, and diabetes. And what we call vascular disease, where the blood vessels are clogged up with cholesterol plaques. Or they may have a history of previous strokes or abnormal heart rhythm, because the way the heart beats sometimes results in some clot formations as well. So therefore, there's some promise in this. If we can manage high blood pressure, high cholesterol, all the underlying risk factors, and diabetes well, we can actually reduce the risk of this kind of strokes, or slow its progression. So there are many other kinds of dementia that I wouldn't go into details here, because there are many causes. Sometimes it may relate to Parkinson's disease. There's another kind of dementia that we call Lewy body dementia. But what I would like to focus a little bit on is how do we reduce the risk of dementia? Some of the risk factors of dementia is non-modifiable. There's very little that we can change. For example, age. The older people get, a bigger fraction of individuals in those age group may be diagnosed to have dementia, and it gets, in a way, worse and worse. Sometimes it's a lot to do with genetics. Someone in the family got it, and it's more likely that another person in the family will get it as well. And similar thing for his family history, sometimes it may know a lot to do with gender as well. This is non-modifiable, so there's very little that we can change about it. But what we can modify is, during our healthy years, focus on physical activities. What helps is also mental stimulating exercises or activities. It may be playing chess, it may be involved in puzzles, games, it may be involved in group activities. So all this helps. And of course, we can actually manage the vascular risk factors. We talk about the 3 highs: high blood pressure, high cholesterol, or high blood sugar. And this is actually quite prevalent in our local population. You can treat this well. We reduce the risk for not just, I would say, not just strokes, dementia, but a lot of other conditions, acute ischemic heart disease. And of course, some drugs may make it worse, either the symptoms of dementia, and we try to avoid that. This is very controversial. Some of the other risk factors that sometimes you read in the literature, people may say that educational level may make a difference. Higher educational level, there's less risk of that. But I guess it's in part due to the one's involvement in mentally stimulating exercises. So I think you can relate to this somewhat in that the brain is like just any other muscle in the body. The more you exercise it, the better it is in terms of health and functioning. Others may say that the body mass index is related to that. So this is, I think it's also related partly to the 3 highs we talked about. High blood sugar, if you are somebody who has diabetes or high cholesterol, invariably it tends to be plumber compared to the rest, and this can be a problem, a weight issue. Depression, there are some literature around alcohol and smoking. This is in themselves, alcohol and smoking also make conditions like cholesterol worse. So you can see maybe there is a somewhat tenuous link between ultimately leading to dementia or strokes. Okay, so it is one of the, all this can be related. Alcohol and smoking are not good habits to have, and they can have a lot of health problems later on in years. And some may actually espouse taking ginkgo, omega-3. Let's say it's good for mental functioning, vitamin E, vitamin B, and folic acid. But I would say that generally, if one's diet is well balanced, you are going to have invariably most of the vitamins that you need, rather than taking more supplements. And there's statin is a drug that we use to treat cholesterol. So there may be the evidence in this relation to dementia as well. So what do we see when individuals are diagnosed to have dementia? How do they present? So I want to differentiate first between what is normal aging and what we see in dementia. So when does it become a disease condition and needs attention? So as we age, we realize that what will possibly decline is the ability for us to problem solve. We may take longer time or more difficulty to remember new things. There may be problems in creativity or short-term memory. Okay, however, we should not see any difficulty or impairment in judgment, in longer-term memory, in our social and occupational functioning. That means the social skills that we have in making friends and interacting, and our functioning at work, our ability to work. So if someone finds they have particular difficulty in their work when it used to be not a problem at all, this may need to be investigated further. And of course, our ability to live independently. Okay, we often refer to this as activities of daily living, or ADL, or independent activities of daily living. In dementia, you see a different picture. It is not a normal process of aging. There is evidence of significant cognitive decline. That means a significant decline in mental functioning from a previous level of performance. And the cognitive deficits will interfere with the independence of day-to-day life and activities, such that often others have to step in to help them. So the natural history of Alzheimer's disease is when it's diagnosed, there will be a phase where you go through phases of, if diagnosed early, mild dementia, and generally you may see cognitive symptoms, that means problems with the mental functioning presenting first. And as you get from mild to moderate, you start to see a loss of functioning, loss of ability to live independently. And for some proportion, some may present with behavioral problems slightly later on in the moderate to severe period. And in the severe subgroup of people with dementia, you'll see they may require nursing home placement, and eventually leading to decline in physical health and passing away years later. So when we talk about cognitive symptoms, what do we mean? So because it affects parts of the brain that deals with memory, you find that individuals with dementia tend to forget recently learned information. It can be the names of people, and sometimes these are people that are very familiar to them. It can be the daughter, it can be your children, their relatives, and this is very striking. Sometimes they may have problems recalling recent events that has happened. They may forget that they just had their breakfast. They may forget what happened, where they kept their things, and that leads them to look around, scrounge around the family to look for items that they have misplaced, and they might have thought that as a result, somebody might have stolen them or something has happened in their house. So they will put things in unusual places. It can be, I mean, the examples of putting the purse, for example, in the freezer, repeatedly misplacing objects. And this suddenly leads to think that somebody actually has stolen that instead of I have put them in a place which is unusual. They have problems with planning. They can't multitask and they can't problem solve that well. Okay, which may mean they have problems buying the right amount of food to cook, unable to cook a new dish, or to cook for a different number of people, have problems keeping track of their medications, have problems paying their bills and the utility bills and so on. And they don't know what to do when there is a power trip in the house. This can cause a lot of problems, evidently. Judgment is impaired, and sometimes you find that they may actually end up spending money on things that they shouldn't have, like paying for home repairs they do need, wearing several layers of clothing on a warm day, having problems driving. Sometimes they have difficulty in performing familiar tasks. They are unable to prepare meals now. They couldn't prepare meals. They couldn't draw money from the ATM. They are unable to use household appliances. And they may also present with confusion with time and place. A few individuals actually we know have problems of getting lost frequently. So sometimes it can be the first symptom of dementia. They got lost, they forgot where they are, or they have been less and less aware of time and place. Sometimes the police might be needed to bring them back. Sometimes they are unable to tell passerbys or police where they're staying, or the phone numbers, or who to call to get them back home. So they have problems. They may also have problems recognizing objects and persons. Earlier I said you may have problems remembering names, for example. Sometimes in the severe conditions of dementia, they may forget. They can't recognize their family members, their daughters, the sons and daughters, or their spouse. They can't recognize objects, or they can't name the objects. So they use very vague and generic terms sometimes, not calling it a pen or pencil or TV or 9x, some other vague term, or referring to a person not by their name but by pointing or other vague terms or reference. So they have problems with language. They can't find the right words. They forgot simple words. Their writing and reading skills may actually get worse. So people with dementia may also have problems maintaining emotional control. And that's where we talk about. They may have behavioral disruptions. They may have problems with anger, controlling themselves. And sometimes if you understand that this is an individual who goes through gradual phases of losing skills in what they used to have, it can be very frightening for them on one hand, and very disorienting for them as well. That why is this happening to me? What's happening? Is it the case that somebody stole my belongings, and so on? So they have a lot of emotional turmoil within. Behavioral symptoms. So you find that there are changes in personality. Someone with dementia can change their personality suddenly compared to what is their usual self. They may become extremely confused, suspicious and fearful of others, or dependent on a family member when they're usually not the case. Again, it's also a functioning of a person's memories. If you start to lose them, your terms of reference and who am I and what do I do start to change as well. The way you respond and react to the world also changes. So their mood and behavior can get affected because with all these changes, they can get depressed and anxious. They can have rapid mood swings from calm to tears to anger for no apparent reason. They may be agitated and aggressive, and sometimes they have wandering behaviors. So it may come to a point in which sometimes the family members have to be careful where the keys are kept and keeping a tab on the person, or putting some form of identification on the individual in case there's wandering behaviors. Some of them actually present also with psychotic symptoms. So they may hear or see things that are not there. They may have fixed, unchanging belief that somebody is out to harm them, and so on. And generally, you see that a lot of them actually have the loss of initiative and motivation. They don't like to do the usual activities. So in a clinical context, we sometimes diagnose individuals to have mild or moderate or severe. It's actually a function of how much people around them needs to come in to support them. In mild dementia, they generally would only need assistance in some complicated tasks like financial management, operating gadgets or appliances. But even then, you have to be careful. Sometimes an individual, when he or she starts to cook or boil water, they may actually forget to turn it off. So there may be more supervision required in such instances. And staying at home alone could be a problem. So this has to be thought through. In moderate dementia, they would generally need more assistance, such as in self-care, maintaining their hygiene. They may need some reminders in others. They may need help in self-care as well. It can be brushing teeth, it can be showering, it can be feeding as well, or dressing themselves. So they may have occasional incontinence, they may have problems with the language, and this can be very frustrating. If they have to communicate, they can't find the words, and you can understand why, again, somebody might suddenly flare into anger and irritability. In severe dementia, they need total assistance in activities of daily living. So this is again about feeding, dressing, showering, and things like that. And the caregivers have to come in. There's a loss of language ability, and the ability to move around is very, very constrained. And some of them end up getting bedridden. So this is from the Alzheimer's Disease Association, describing the three phases, mild, moderate, and severe. For example, in mild dementia, the individual appears forgetful, occasionally repeats himself. Sometimes they behave oddly and become withdrawn. They may become lethargic or agitated. Planning of day-to-day activities becomes difficult, but they can still do some of this. In moderate dementia, the changes are more noticeable. Memory lapses are more obvious. Behavior becomes problematic and may interfere with normal day-to-day activities. And some examples of behavior that may be symptomatic of moderate dementia are wandering and getting lost repeatedly particularly, repeating words, neglecting personal hygiene, and they may insist that they have already brushed their teeth or shower when they have not. Losing track of time and events, forgetting the names of common objects and familiar people, such as their family, irritability and agitation. In severe dementia, the individual will be unable to recognize family members and will need help in personal care such as bathing, going to the bathroom, dressing, and eating. Their speech may be difficult to understand and they may not comprehend what's being said to them. So how do the medical team manage clients with dementia? So when individuals are referred to a hospital, so what kind of help can they expect and receive? So the evaluation of dementia will comprise of medical and psychiatric evaluation with detailed history taking from the caregiver and the patient. So very often we need to talk to not just the person who is suspected of having dementia, but also a close family member who lives with them, who is able to tell what kind of changes we see and how long has it been. There'll be a physical examination because we understand that sometimes physical conditions can affect a person's mental functioning. I just talk about, for example, conditions like diabetes, high blood pressure, cholesterol, and other conditions that might affect mental functioning. So there's a mental state examination, which is looking at the mental functioning, and they may include doing some tests of orientation, word recall, planning. So it's kind of a simple test. In psychiatry, we call them mini mental state examination, for example, or MOCA, which is another kind of structured cognitive testing to see how severe a person's cognitive decline may have been. And investigations are often done. So there are blood tests which may look at the possible underlying causes of dementia that may be treatable. Some of them would be sense for neuroimaging, which is a scan on the brain, because you appreciate there may be some changes that could be seen, and psychological testing to see what areas or what domains of their mental functioning is being affected. So all this helps to map out a few things, whether the dementia is treatable or can be, to what extent it can be slowed down, how severe, it may give us an index of severity of the dementia. If you see a brain which is very shrunken up, it may give us an idea of what kind of mental functioning is affected the most in this individual. So we can start to plan how much help they need. So diagnosis, how much help they need will obviously depend on their physical needs, the level of functioning, independent living, and the behavioral issues. Someone who is prone to losing temper, and the family members, they can't function, they need a lot of help. What are physical conditions that they might have? We will assess the social support as well. The family members who live with them or who live nearby, and how much support they can give realistically. Some individuals might require very close attention. If they have, for example, wandering behaviors, or they tend to often forget to turn off the fire and so on, this can be a concern. We have to look also at the psychological need of both the patient and the caregiver. I think this is very important. So as people start to lose a sense of themselves, it's very frightening and destructive, as I say. And the caregiver, because this is a chronic condition, they will need a lot of support, particularly when dementia gets more severe. We have to think about medical legal issues, such as lasting power of attorney, appointing of a deputy to manage a person's affairs or medical care. We have to think about issues such as making out a will. Would this be a good time? When would be a good time? And areas of vulnerability, okay, whether they can look after themselves and what we need to do for them. So all this helps in planning the management and how regularly we need to review them. In managing dementia, we can rely on drugs, pharmacology. There may be some use of behavioral therapy. I think it's also very important that we actually make the environment easier for a person with dementia. Career education is also important, and career support. And of course, for some individuals who can't live on their own, we have to consider nursing home. For others, we may actually be able to use home health service or day center. Sometimes the day center can be a place where structured time can be spent by people with dementia. So that makes their life more fulfilling. And in this structured time, the caregiver also get a brief respite, at least for a certain portion of the time. There are a couple of, there's a few drugs that help to slow down the progression of dementia. So I said slow down because pharmacology, at least in dementia, doesn't cure the underlying disease condition, but help to maintain their functioning, their mental functioning longer. There are two broad classes. One we call cholinesterase inhibitors, and you often hear of such drugs called donepezil, rivastigmine, and galantamine. And these are generally used for mild to moderate kinds of dementia. And another class of drug is the NMDA antagonist, or what we call memantine or Ibiza. And I think that's generally used for moderate to severe kind of dementia. The prescription of these drugs will be advised by the doctor who cares for the dementia patient. As I said, they are not curative, so it doesn't remove the dementia, but it can slow down the progression or the mental decline. And that helps a lot in a lot of these cases, because the more they're able to function, the less dependent and the less stress on themselves and the caregivers. And it does help with the non-cognitive symptoms as well. The downside is that they tend to be expensive, and this is medication that someone needs to take probably for the rest of their lives. Is a daily cost that has to be factored in, and you have to consider other things like side effects. At that age, and with this condition, there are often medical comorbidities, and there are probably many other drugs that they also have to take, and we also have to think about potential drug interactions. So there'll be other medications used for people with dementia. For example, we talk about people who may be agitated and aggression. With aggression, and they may have hallucinatory experiences and delusions. So antipsychotics can be useful in reducing this behavior agitation. Okay, the problem with antipsychotics is sometimes we find that individuals tend to put on weight, and they may have problems with their blood sugar and worsening of the cholesterol, and that may actually aggravate or make worse the underlying condition that we see in things like vascular dementia and strokes. Antidepressants are sometimes used as well because some individuals with dementia has depressive symptoms. So it's great for treating people with depression, anxiety symptoms, or those who have obsessionality problems. And sometimes it can help to reduce the agitation and irritability as well. Benzodiazepines are what we generally know as sleeping pills or anti-anxiety tablets. And for individuals where these are prominent anxiety symptoms, sleep disturbances, sometimes they could be used. But benzodiazepine has to be used very carefully, because particularly in the elderly, there's a risk of falls, and we don't want worse problems like fractures to happen. Sometimes it may also cause confusion as well in the elderly. The problem with benzodiazepine also is that the effects sometimes tend to be longer lasting than we expect. Some individuals might have a hangover effect. If they use it at night for the sleep, the next morning they can still not be in their peak functioning. And again, we talk about the attendant risk of falls. Individuals taking these drugs, benzodiazepines, may not realize that actually my reaction time is slower. So that's even in normal individuals like our age groups. The reaction time when they operate machinery, drive a car, might be slower than they estimated. And this can cause a lot of problems and accidents. And of course, not to say that long-term use of benzodiazepines, there's a risk of dependence. They might find that the effect wears off, and they need to use higher and higher dosages to have the same effect. I think another important domain we need to think about, not just medication, is social recreational interventions. So in the hospital setting, they will explore interventions like music therapy, reality orientation, reminiscence therapy, art therapy, aromatherapy, pet therapy, and sometimes I think religious activities can help as well. So essentially, these are activities that engages different domains of the brain to keep them active, and in other areas to make life fulfilling itself. So I want to spend some time talking about general advice for caregivers. This is really important, especially in our context where we are likely going to see more and more individuals with dementia. People are going in for the long haul, and it's important to think about looking after ourselves before we can start to care for others, particularly when the condition is likely to progress in its severity. So looking at mind, body, and brain. So I guess it's not just for the individuals with dementia, but also for the caregivers that a balanced diet, enough fruit, vegetables. This for the people in dementia is also important, equally important, perhaps even more, because this helps to prevent constipation. Regular exercises is important in all stages of the condition, because once we see the individual starts to get bedridden, a lot of medical problems starts to emerge as well. And interaction with the families, time with the families is very important to get the person engaged socially. We talked about environmental manipulation earlier on. So for the house, it should be well lit. For places like the washroom, the toilets, there should be handrails as well, so that can prevent falls. Similar reason for anti-slip mats. Okay, and then it's probably good to throw away unnecessary furniture and remove the clutter as well, because you don't want individuals to accidentally knock into things, already having a high risk of falls. So if there are cables, wirings and cables, it's good to tie them out and keep them out of the way. There shouldn't be any carpets. Among other things, it can be not very hygienic. And of course, to keep dangerous items such as knife, medications or detergents away. Sometimes there may be confusion about what these items are for. So like putting detergents into cooking and severe kind of dementia, taking the wrong kind of medications, and so on, or using a knife to pry something out of a bottle. So this can be very dangerous in itself. And switching off, being around and switch off the gas supply if they are not, individuals are not cooking. I think it helps to provide some recent photos and context. Always good to have it in easy access so that they can be used if they're needed. Have contact information on the individual in case they get lost. So their address, who to call when they need help, when they're outside. So when we interact with individuals that suffer with dementia, simple things like facing the client, smiling, nodding the head, using simple short sentences, speaking slowly, repeat what we say, or if they appear unsure, repeat what we just said. Give them simple choices and less open-ended questions. Okay, that means that it may be a kind of a yes or a no. Rather than getting them, what would you like for lunch or dinner? So for caregivers, what should be approached for managing difficult behaviors? It's not helpful to argue with them. It's good instead to simplify the activities that they have. Try to make things as routine as possible. They may do poorly with new activities, something which doesn't fit the usual pattern of the day. Always be there, be encouraging, provide positive feedback. You might have to be quite good in learning to look out for pain. Sometimes they may not complain about it, or discomfort, or constipation, or feeling tired, or having an infection. So it's good to look out for, for signs of distress, sometimes unwellness in general. So the next two slides are more of where to get help, how to get help. So you can take a picture of this. There's a lot of agencies out there is for helping those who are affected and also caregivers as well. For example, the Agency for Integrated Care, Lions Befrienders, the Seniors Helpline, and the Dementias Helpline. And IMH itself has services for individuals with and caregivers for dementia. There's a community psychogeriatric program. We tend to divide our healthcare nowadays by the regions in Singapore that we live in. I would say most hospitals would have geriatric medicine or psychogeriatric services somewhat to different extents, and some places are quite well equipped, like Changi General IMH may have a bigger group of psychogeriatricians working there. Of course, we have IMH, we have the Aged Psychiatry Community Assessment and Treatment Service, APCAT, that I just talked about, and Dr. Yao, where most of these slides came from, is actually heading this service. So I believe I come to almost end. This is the last slide. So how to get help? You can bring someone you know who is suspected to have dementia to a clinic. At the start, polyclinic, of course not in this circuit breaker period, but generally they would have shared care teams, or they may have specialist clinics. In IMH, certainly we have a specialist clinic in psychogeriatric medicine where people with dementia are managed. You cannot bring the individual to a clinic. I think a good starting point would be a family service center where they can have to link up with the community psychogeriatric team. So at this stage, IMH and most of the hospitals are working very closely with community partners to where they can help with maybe the first cut, and for more specialist referrals, they can help to initiate referral to specialist services in the hospitals. So with that, I end my talk, and I'll be happy to take any questions from the audience.
Dr. Goh, you can share your screen.
Sure.
So Dr. Goh, thank you again for a wonderful talk. How is Parkinson's disease different from dementia?
Parkinson's disease is a condition that affects a person's movement. They have what we call a shuffling gait. They may have a fine tremor. In some individuals, Parkinson's, they may actually have a dementia. This is associated dementia in some individuals. I would say that not everyone with Parkinson's will have dementia, but it is there's a type of dementia that is related to Parkinson's. So it's one of the, if you remember, one of the bottom 25% where Parkinson's is a small part of it.
Thank you. I think you mentioned something about stress can actually accelerate dementia. Can you elaborate a little bit more on this?
So earlier I was talking about sometimes individuals with dementia, they could be easily stressed because as a person lost grip of their reality, they may tend to lose things easily. They may be frustrated trying to find the name of their son and daughter to call. They may be very upset they can't remember the phone number to call, and this can lead to emotional outbursts sometimes. Because remember that our memory forms the basis of our identification as who am I. So when you start to lose grip of this, there's a lot of questions, a lot of uncertainty, a lot of doubt. And this can lead to, dementia can cause all these problems. I would say that is the other way around. Stress, there's no direct link between stress causing dementia, but what I would say, sometimes the dementia are preventable, okay? And if we reduce the medical conditions that contribute to vascular dementia, we can help to reduce the risk of getting vascular dementia, such as if you treat diabetes well, manage high blood pressure and high cholesterol well, you're less likely to have a kind of dementia known as vascular dementia, which forms 25% of the overall group. So generally, stress has no direct relation to dementia, but I can understand that stress actually causes a lot of psychiatric problems as well, like depression, anxiety disorders.
Thank you, Dr. Goh. Does a person with dementia, would they really start to change their eating habit or things they like?
Starting to change their eating habits. It's possible because sometimes they may have less access to the types of food that they like. You're going to lose skills in cooking. You're going to lose skills in finding a way around the neighborhood to get the food that you like. So my sensing is that as their circle of functioning gets smaller and smaller, because their ability to win around getting what they want is impaired, they may have to stick to fewer choices, and that may mean that they have to get what is easy at hand rather than going out and search for it. So I don't think they may have new things that they like to eat, but it may be the case where they may have no choice but to stick to what they have.
They won't change their taste, right? I mean, their sense of taste will still be there, right?
The sense of taste generally is preserved. We see the main problems in dementia is problems with language, problems with memory, and related to the memory is the problems with orientation. Orientation means that you know who you are, you know the people around you, you know the time of the day, and you know the environment, the place that you're at. So when you start to lose track of things, where you are, for example, if you are at home but you thought that you're in a police station, or in a hospital but you thought that you're at home, it can be very disorientating.
Thank you. I'm reading a few questions, trying to do a bit of consolidation here. Is there any side effect with dementia drugs?
I think most of these drugs would have side effects on its own, but this should be discussed with the doctor before discontinuing. The problem with this age group, when there are many medical conditions, is sometimes it's very hard to attribute the side effects belong to this drug rather than to the high blood pressure or the diabetic medication that they might be taking. And of course, sometimes one drug may cause the other drug, the dementia drug, to be more or less effective. I would say they are, but keep a lookout and communicate with the doctor on this.
So, Dr. Goh, activities such as playing mahjong, karaoke, playing musical instruments, are they good for delaying and slowing down dementia?
I would say these activities helps in keeping the individual engaged. So if you use the analogy that the brain is just like another muscle, it's like a muscle in the body. The more you exercise it, the more you use it, you tend to preserve its functioning better. So if you look at the social interventions that earlier on I listed, it also include things like music therapy, art therapy, and I think mahjong is an excellent way of keeping people engaged as well. Reminiscence therapy, I didn't talk too much about it. It's basically involve holding an item that is familiar to the individual and say, what do you know about this? Do you remember things around there? So these are good at exercising, for example, recall, organizing a person's skills, using a person's judgment. In mahjong, I'm sure you use a lot of that. And music therapy, feeling engaged in the moment, enjoying certain things. So all this helps because there are other symptoms of dementia that is affecting an individual too. So don't forget that people may be anxious, they may be depressed, and all this helps a lot.
Thank you. Does taking B12 supplements help?
I wouldn't say it specifically helps in dementia. Vitamins, if you take a well-balanced diet, generally you don't require additional vitamin supplements. Whether B12 specifically help, I'm not aware of any research that shows that it specifically helps to reduce the risk of dementia or slow down the progression of dementia. But there are some other research on other substances like ginkgo. Again, I put it under controversial. We're not sure whether the evidence is robust enough that it shows a slowing down of dementia.
Are we seeing a trend whereby dementia is happening more in the younger age group?
Not to my knowledge, but certainly what is a sure thing is the incidence of dementia in each decade of life gets higher and higher. For example, in the 60s will be lower than the 70s, 70s will be lower than the 80s, and at 90s is actually quite a fair bit of the population who end up maybe diagnosed with dementia. Occasionally, the example I showed is someone in the 50s when the first case was described. I would say that was unusual. Some people are nonetheless diagnosed to have dementia, dementia-like conditions in their 50s and sometimes even earlier.
Thank you, Dr. Goh. Is there a trend whereby the rate of increase of people having dementia is higher now, or just basically due to the aging population?
The main contributor to the rate increasing, at least in our context, is our population is rapidly aging. So if you think of it as a fraction of the older age group and the population at large who are older is bigger, you're going to see more. I think what we're currently doing about diabetes is a good thing. As we see the condition, there's more awareness of the risk factors of diabetes and the importance of managing chronic health conditions like high blood pressure and high cholesterol. I hope that this can actually lead to less comorbidities, less problems associated with these conditions. And one of them is dementia.
Yes, Dr. Goh, we have Dr. Naras, a dietitian and nutritionist,
Yes,
doing our
sure. Okay.
And we are starting to see, diabetes being one of the risk factor in cancer, in stroke, and now is also even in dementia.
Yes, no, I would agree with that because conditions like diabetes, they actually affect not just the blood sugar, but it leads to a lot of organ damage. And managing these conditions, well, in our prime of youth, we will never think that, oh, our diabetes just require medication and it's not a big problem than just taking medication and remembering to take it. But if you see that the damage is cumulative and it adds up with each decade of our lives, you begin to appreciate that how important it is to manage these conditions well, because you are going to prevent dementia, ischemic heart disease, the risk of strokes, and so on.
Now, typically, the elderly actually don't sleep so much. They may sleep for between 5 to 6 hours. Would that really be sufficient for them?
Okay, we used to think that the elderly doesn't need to sleep as much. As you say, quite rightly, would it be 5 to 6 hours? We saw that individuals who are elderly, they may get up earlier. But I would say that I think there seems to be a shift somewhat recently that maybe the optimal amount of sleep should be more than 5 to 6 hours. Perhaps the optimal amount should be around 7 hours to 7.5 or 8, even 8. Because it's during sleep that the brain heals itself. So when the body is not moving around, and all this helps, I think generally in terms of, it's very obvious when you realize that with enough sleep, the ability to concentrate gets much better. So even in a normal individual, you focus better, your mood gets better. If you lack sleep, the opposite is true. You tend to, for example, make small mistakes like typing. You tend to forget things. You tend to have less ability to keep track of multiple things happening in the environment. Okay, and sometimes you get more irritable. So we know that when you lack sleep, you have that. So I would say that if a person is used to 5 to 6 hours and everything is fine, maybe it's all right. But if things are not great, especially compared to before, maybe they should try to sleep a bit more.
Ching San, there are lots of questions in the Q&A section. Please read them off because people are waiting for them to be answered very specifically to their questions.
Yeah. So Dr. Goh, to what extent is dementia preventable or reversible?
Okay, I'll try to keep my answer brief because I answered a lot of questions. So there are conditions, there are types of dementia that is prevented, as I mentioned earlier on, those related to vascular dementia, where there are known medical conditions that can be reversed or managed well. So diabetes, high blood pressure, and high cholesterol. Okay, I would say dementia is a progressive condition. What we can do is to slow down the progression, and the pharmacology, the drugs are meant to slow it down. I wouldn't say dementia is reversible. So as of now, I'm aware of any research that shows that we can actually reverse the cause of dementia.
So if let's say someone has a parent with dementia and they stay with different children on different weeks to ease the caregiving burden, would that also help to keep them active and mentally alert?
In this arrangement of staying with different caregivers, I think it helps because it eases the caregiver burden. Okay, I anticipate this might lead to some disorientation as well when they're grappling with where am I and what do I do, whose house is this, who is this person. As the dementia gets worse, this can cause more disorientation. But if prepared well, the caregivers may be able to manage some of the negative reactions, and it may be more opportunities for engaging in different type of behaviors in each setting.
If a dementia patient refuses to meet old friends, family members, accusing them of being mean, what should the children do? Should they go along with the false accusation to avoid these people, or clarify and encourage them to meet up?
Okay, I would, my approach would be to think of the underlying reasons why they accuse their close friends of being mean. If it is related to a psychotic symptom like delusion, that these people are doing something bad to them, then it is treatable. And there are medication and ways of doing that. So treat the underlying cause. If it's a result of apathy and lack of motivation to meet up, okay, then maybe we should encourage them, because having them engaged is always better than keeping them at home.
For a dementia patient, let's say in the home, by putting up signs on the wall, for example, reminding them where is a toilet, where to keep the things, or to remain calm, would that help them?
Oh, sorry. Could you repeat the question again?
So for a person with dementia, by putting a lot of writings on the wall, so for example, maybe the place that they put their wallet, to the door for the toilet, would that be helpful to keep them calm and help them with the daily lives?
Yeah, I agree. So this is very good suggestions for environmental simplification. Okay, so having clear signage, having I would say reducing the clutter and labeling things, keeping it simple. So we should try to simplify the routine as much as possible. And other things might be to maybe to get rid of unnecessary or unneeded furniture. So have a fixed place and a clear place for taking things from. That would help.
Dr. Goh, you mentioned about statin that is used to treat high cholesterol. It can cause dementia. Am I correct?
No, I wouldn't say that it causes dementia, but the statin is actually, interestingly, is that by reducing the high cholesterol, it may actually help. It may actually help to slow the progression of dementia because you treat one of the underlying causes. Okay, if you treat the underlying causes of high cholesterol or diabetes, it can actually slow the progression of future strokes in the brain, which may actually cause the dementia to get worse.
Thank you, Dr. Goh. Dr. Goh, can you elaborate on Lewy body?
Lewy body dementia is a kind of dementia where there are some changes seen in what we call histopathological findings. If you look under the microscope, you could see some of this. It is a kind of a dementia that has a very slightly different presentation, but it may be difficult. I would say it's difficult to just diagnose it purely from how a person presents. Sometimes this may require further investigations. It may not be that useful to actually go for the particular type of dementia, sometimes because actually managing the emotional, the cognitive functioning may be more important and the environment is more important.
Thank you, Dr. Goh. There's a few questions actually on sleep, and there's a comment about for 7 and 8 hours of sleep, if it is supplemented because they take a nap, would that be having a total of 7 to 8 hours? Is that sufficient?
Okay, so again, the good sleep practices. Right, so the problem with taking naps, sometimes we find is that person may have problems as a result to fall asleep during the night, and that's not a good thing. Okay, so the amount of sleep should be, I would say, give yourself enough allowance during the night for around 7 to 8 hours at the stretch. And if you have problems sleeping, it's always good not just to lie in bed with eyes wide open, but do something which is not too exciting for the brain. So don't watch a thriller when you cannot sleep at night. Some people advocate actually better to get up and read a book because that in itself actually makes the brain tired without causing too much activation, and then go back and try to sleep again when you feel tired. Taking a nap, I would say, is sometimes if you take naps but in the day but don't sleep well, it's actually quite counterproductive.
Thank you, Dr. Goh. For a person with dementia, will his vision be affected in terms of color distinction or depth perception?
I'm thinking more broadly. Sometimes the reasons that causes dementia may affect this. For example, if I think about strokes, mini strokes, that may not appear obviously, but may have hit parts of the brain that deal with this. I can understand why it can be affected, but it wouldn't be a direct result or direct presentation of dementia.
Thank you. At old folks' home, sometimes you see the resident were given dolls to carry. Is there any theory behind this?
So what was DOS
I think
to
they were
carry?
given like dolls.
Okay. Right. I'm not sure why it was given to them. But if there's a function, if there's a reason for that, it's something that they can identify with or have fun with. I don't see why not. Essentially, we're really talking about structured activities or activities that they like or they enjoy in, right?
Yeah, so I guess if they feel like it is comforting, it's just something that makes them
Right.
happy, right? Yeah,
Right.
okay.
I know there are other modalities, there are other things considered like gardening. So is that helpful? And there will be some would say that it's good for managing stress, it's good for the brain, and all these are actually considered, I guess, at one time or other in our psychogeriatric department.
So there are some elderly who tends to stay at home. They do not want to go out. They do not want to socialize. And would it be a good idea to engage with different family members regularly to delay the onset of dementia?
So I think keeping the brain active is good to actually activate parts of the brain, remembering, recall, repetition helps in memory as well. So if you cannot get a person to recall, you can actually remind them and get them to lay down new memories. I think it helps. Different family members, yeah, I think the more social contacts help rather than sitting alone in a house when you tend to start to lose grasp of reality. Sometimes some may benefit from day centers as well. Again, there can be structured activities in these day centers, and this can help too.
Dr. Goh, how does one differentiate between normal aging, whereby sometimes we will forget things, versus dementia?
The most obvious aspect of dementia is that it is progressive. That means it's worse and worse. And in normal aging, we shouldn't see loss of functioning, particularly that affects your ability to live and work on your own. We shouldn't see us having problems with what we call activities of daily living. Feeding ourselves, dressing ourselves, showering, this shouldn't be a problem. Okay, for important information, we shouldn't have problems remembering. So names, faces, telephone numbers, we should not have a problem with that. But if there's any concern, it's always good to actually refer them to a specialist. And sometimes we do get referrals for those who are worried family members might have dementia and where formal testing can be done.
Is it true that losing one's sense of smell is an indication of losing part of the memory or having dementia?
Losing sense of smell is not specific to having dementia. I would say if this happened, I would advise maybe referring to a physician to have further investigation, because the sense of smell, it may be a sensory problem, ability, the part of the brain that deals with smell may be affected. So I'm thinking really whether there's a need for a scan or the need for some further testing, or what kind of smell can be received and what can't.
So for a senior who maybe sleep for 3 days and then stay awake for 3 days, is this something to be concerned of?
I would say it's a problem. You don't often see that. Generally, you may see individuals who have it sounds like a sleep problem. I do not actually know the specifics. Sleeping, sometimes it may be we can see in some conditions like I'm talking about mania, where it's the opposite of depression, where you get a lot of energy, and when you're in a high, you tend to be awake for many days at a stretch. but at the end of it, all your energy get used up and then it sunk into a very deep stupor and sleep. So I'm not sure whether the not sleeping for 3 days is accompanied by a period of a lot of energy and then they burn it off and they get too tired. So maybe that they may be a psychiatric condition that need to be explored further. Sometimes people with dementia may present with some of these problems as well. And again, I would say it's good to get all this sorted out with a physician.
Thank you, Dr. Goh. So someone asked if there is it a symptom if someone keeps cleaning the floor, for example, 5 to 6 times, even during the middle of the night? Is this an indication?
Okay, I can think of a few scenarios here. So somebody who does things repeatedly, they may have a preoccupation with cleanliness that is not clean. So it may be another condition such as obsessive compulsive behavior where it is a undue preoccupation with cleanliness and they cannot tolerate any suggestion of dirt, even though it's not true. But for dementia, sometimes that happens when they may go and shower again, they may clean the floor again because they forgot. They forgot that they just clean the floor, they forgot that they just shower. So again, so it's back to the underlying reasons why they do that. It may be a presentation of dementia when they cannot remember doing it again.
So we have a question here whereby this patient has dementia and the patient refused to believe her mother have passed away. So is it better we tell the truth or we just let her believe that her mother is still alive?
It is a difficult question without knowing the person. I would advise what is the utility, what is the use of telling the person the truth, but also advise not bluffing, not lying to the individual. You're not going to get a solution when you say the person is alive and I say, the person therefore requests, can I see him or her now? Okay. On the other hand, I would say maybe as I advise, it may be pointless to argue with somebody's belief, particularly it's kind of have a strong intensity. Even if it is proven right, you lead to more distress. So what may be useful is perhaps not to lie because you get more difficult questions. Can I see now? And not to tell the truth to the extent that you upset and agitate her, but rather to engage in activities all the while that they continue to enjoy.
Yeah, I guess, Dr. Goh, it is really very situational and we do need to understand a little bit more the context.
Yeah.
So, Dr. Goh, what is the percentage of elderly getting dementia in their 70 and 80 years old? That range.
Yeah, so I don't have the numbers off the cuff, but I know that for those age 60 and above is around 10%. So that's the average across all the different age groups. But what we know is that what can be easily obtained is actually in the 60s, the percentage of those with dementia is going to be lower than those for 70 to 80 and 80 to 90. But then again, I would caution if we want to know this to assess what's the risk of getting dementia, we might not want to worry ourselves unduly because at the end of the day, it's just a number. What's important is that I think it's important to be able to detect, hopefully with today's talk and more information from healthcare professionals, when dementia is likely and get early help for these people.
So, Dr. Goh, just now you answered the question about someone who keeps cleaning the floor, and then we have a viewer that says that maybe an elderly could be eating every other hour. Would this be possible, a sign of dementia as well?
But sometimes in those with memory problems, I encounter individuals who say, I didn't have lunch yet, even though obviously they had lunch earlier on. But this might not actually lead them to take food again because they might find that even though I thought I didn't have lunch before, I'm actually not hungry. So it's very possible that a person can forget that he has lunch or forget he does something, I want to do it. But in the context of eating regularly, really there may be more reasons than that.
Thank you, Dr. Goh. Has IMH any studies related to mindfulness, and is that recommended for dementia patients?
At the moment, to my knowledge, I don't think so, but I think it is something that would be interesting and useful to explore further, because when you talk about mindfulness, is awareness of ourselves, ability to manage our emotions better, and certainly in the context of either as a caregiver or even as a sufferer of a condition like dementia, is actually very important.
Dr. Goh, there's a question about coconut oil. Is that beneficial to prevent dementia?
And for coconut, I'm not aware, to my knowledge, coconut oil actually helps. When somebody has information on that, it's probably good to look at the underlying basis. Generally, we are looking at what kind of studies are being conducted in the population, and how do they say that this person is, the risk is lower with treatment.
Another question is dementia inherited?
Sometimes it is. There are genes that may predispose a person to having certain kinds of dementia. So sometimes more directly than otherwise. In some types of dementia, it may be more genetically inclined. For this, you might see, for example, that if it's genetically very heavy genetic loading, maybe younger individuals may be affected rather than older, rather than much younger than expected, basically. For example, in conditions like Down syndrome, there is a higher prevalence or incidence of dementia when they're really young. We didn't expect normal people to have dementia until they are perhaps 60s, but for those with Downs, it may be decades earlier.
So there's a question about how can caregiver help during episode of disorientation by the patient?
So disorientation, just to be clear, it can relate to time, what time it is, thinking that it is night when it is the day or the otherwise, or disorientation to person. Who is the person in front of me? This nurse is actually, I don't know, this is a nurse. I thought this is a police officer. I thought this is my daughter. It can be disorientation to where I am, being in the hospital, but thought that he's at home or he's in a police station. Okay, so how do we, I guess the question is how to manage instances of disorientation. I think what helps is maybe more broadly is to keep the routine as simple as possible. So if it's the environment, it's something that you can manage the environment in their own home. Sometimes it's helpful to have recent pictures, photographs of family members in the house that may help somewhat. It may help with reorientation by constant reminders. This is this place, this is this place, without arguing with the individual. It is a strong belief. Sometimes it may be like keeping the curtains open to have reminders that this is the time of the day. Basically, it generally revolves around keeping the routine simple, I would say, and predictable.
Thank you, Dr. Goh. Dr. Goh, is there any link between metallic utensil, maybe I'm guessing non-stick pan, any relation with that to dementia?
Again, I would say, not to our knowledge, that the utensils may actually cause problems with dementia.
There's a question about someone who is consuming Zomic in their 20s. Can they get dementia?
So can you repeat what is the thing that they consume?
I think it's ZOMIG, zomic.
I'm not familiar with this, so I'm able to answer this question. Zomic.
Okay, sure. Thank you. Yeah, Dr. Goh, just bear with me. I'm scanning for other relevant questions. Dr. Goh, is there any finding why dementia is on the increase other than the larger aging population? Anything to do with watching TV, handphone?
I don't think so. I think generally is dementia, as you know, is a acquired condition. Acquired means that it's not something that you're born with, but actually the interaction, the body's interaction with the environment. And as we grow older, some of these insults, the negative impact for the environment will get more and more. It's just cumulative, so it affects the brain, and therefore the incidence of dementia may be higher.
Dr. Goh, someone who has dementia, sometimes they will treat family members as stranger, and they may be against or beware of them when they approach. Any recommendation how these people can find a way to approach them so that they don't feel threatened?
So this is what we refer to earlier on as disorientation, but to persons. Okay, so they may forget a few things. Close family members, how they look like. They may forget the names. They may forget their relationship, and sometimes it may help to have recent family photos, which may have the dementia sufferer together with the family members around in the house for easy reference. Basically, to have these things easily on hand, and to maybe do some kind of a reminiscence. This is your son. This is your relative. So this may help, but we appreciate that dementia is going to be progressive. Sometimes when they lose the ability to recognize, it can actually get worse. But small reminders along the way helps.
Thank you, Dr. Goh. You have answered a lot of questions. Thank you so much. And I think we would like you to come back again for another day. So let's keep in touch. And I'd like to thank all the viewers for attending this. And Bram Center do conduct a preliminary dementia screening. So if you would like to make an appointment with us, you can send an inquiry to info@bramcenter.com. And if you want other details, our Facebook link, services that we provide, you can go to www.bramcenter.com. Thank you very much, everyone, and have an extended long weekend. Bye-bye.
Everyone.